Hello all, welcome to my channel. Today we are discussing another topic on Mrcp Part 1, which is infections. Infections as such carries a weightage of around 14 questions for Mrcp Part 1, and the topic is huge. It's vast and there is so much to go through infections. So I thought it's better to have an overview of different subtopics that come under infections, especially bacteriology. If you have an overall idea of what you're dealing with, then it becomes easier. So today is a video dedicated on bacteriology. We are discussing various gram-positive, gram-negative, the clinical manifestations of different bacteria, what are the lab investigations we are usually doing, what is the treatment modality, because those are the kind of questions that are being repeatedly asked for Mrcp Part 1. So let's get into the video. So today's bacteriology. As you know, bacteria, the whole family, is mainly categorized into gram-positive and gram-negative based on gram staining. Again, gram-positive could be cocci or bacilli based on the shape. Cocci means spherical, bacilli means rod-shaped. Again, gram-negative could be cocci and bacilli. There are some which are not falling under either of this. That's called coccobacilli. And there's some overlap between even bacteria and fungi. There are bacteria that can behave like fungi. There are bacteria that are behaving like virus. But majorly it is categorized and characterized as a bacteria. So we'll see a quick revision of each of the class. So first we'll discuss gram-positive. So gram-positive bacteria are again categorized into two major classes based on the catalase test, as catalase negative and catalase positive. So catalase positive is our Staphylococcus, which is spherical and they are in clusters. Okay, so it is a cocci, so it is spherical shaped, it is gram-positive and it is catalase positive, and they are usually grown in cultures as clusters. So you'll have a BB culture report stating gram-positive cocci in clusters. So that points to your Staphylococcus. Whereas your Streptococcus is catalase negative. Not only that, it is a cocci, but they are growing in pairs and chains. So in your culture report, it might say it's a gram-positive cocci in pairs and chains. So that is pointing towards your Streptococcus. So these are our major two classes of gram-positive cocci, Streptococci and Staphylococci. Both of them are causing mainly skin and soft tissue related infections. We'll see what they are mainly causing. So coming to Streptococci, Streptococci are again divided into different subclasses based on the pattern of hemolysis on blood agar, as alpha hemolytic, beta hemolytic and gamma hemolytic Streptococci. Our alpha hemolytic Streptococci means there is partial lysis on the blood agar and they are mainly Streptococcus viridans and Streptococcus pneumoniae. And we'll see a little bit detail on Streptococcus pneumoniae. So Streptococcus pneumoniae are lanceolate shaped diplococci or lens shaped diplococci. They cause lobar pneumonia, empyema, pyogenic meningitis. It can cause osteomyelitis, septic arthritis, endocarditis, pericarditis, peritonitis, and sinusitis. Okay, so it is one of the commonest organism of causation of pneumonia, lobar pneumonia, and can further worsen and form empyema. It can cause meningitis. Okay, and it is a capsulated organism, and usually in splenectomy patients, we are giving pneumonia vaccine, okay, pneumococcal vaccine. It is ideally given 2 weeks prior to the procedure of splenectomy, and the pneumococcal vaccines are PPV 23 and PCV 7. Okay, pneumococcal conjugate vaccine and PPV 23. That is alpha hemolytic. Coming to beta hemolytic. Beta hemolytic means there is complete hemolysis and they are further classified into 20 serogroups. and the major of it is Streptococcus pyogenes. And when we are simply saying Streptococcus, we are usually talking about Streptococcus pyogenes because it is causing the major skin and soft tissue infections. And these are some of the manifestations like scarlet fever, which is characterized by a strawberry tongue. There are a rash on the face, so that is scarlet fever. Then it can cause pharyngitis. It can cause impetigo, which is a skin related infection. It can cause necrotizing fasciitis and cellulitis. It can cause acute rheumatic fever and PSG, and that is post-streptococcal glomerulonephritis, which is usually presented after 2 weeks of a simple throat infection. So these are non-suppurative infections like acute rheumatic fever and PSGN. It can also cause streptococcal toxic shock syndrome, that is STSS. Usually, when we talk about toxic shock syndrome, we are referring to the staphylococcal toxic shock syndrome, but streptococcal can also cause toxic shock syndrome. That is called STSS. Okay, we have PANDAS, which is pediatric associated pediatric autoimmune neuropsychiatric disorder associated with streptococcal infections. Okay, just remember that there's something called pandas, which is caused by again our streptococcus pyogenes. That is our beta hemolytic streptococci. Coming to gamma hemolytic streptococci, it causes no hemolysis and is enterococcus. Okay, enterococcus is now considered as a different subclass. Okay, that is a gamma streptococci. It was earlier considered under beta, but now it is gamma. Okay, that was streptococci. Coming to staphylococci could again be classified based on the Coagulase test as Coagulase positive staphylococci, which is a Staphylococcus aureus, Staphylococcus aureus, and cons. Cons is Coagulase negative Staphylococcus. Coagulase negative Staphylococcus. Coagulase positive is Staph aureus, and Staph aureus is mainly causing our skin and again, so skin and soft tissue infections and other infections. So it can cause osteomyelitis, septic arthritis. It can cause again cellulitis, abscess, necrotizing fasciitis, mainly streptococcal. Cellulitis, abscess can be caused by both, and can cause mastitis in breastfeeding mothers, especially it is spread from the oral cavity of the baby. It can cause surgical site infections, it can cause pneumonia, and it can cause cavitating pneumonia like Klebsiella and Staphylococcus aureus. They are all causing cavitating pneumonia. And it can cause discitis. Especially, there are some questions being asked where they give a history of valve repair or some prosthetic valve repair or any cardiac surgery, which is followed by maybe 2 weeks later they present with severe back pain. So that is pointing towards a staphylococcal discitis. Okay, so the causative organism there is Staphylococcus. It can cause endocarditis. Now, the overall most common cause of endocarditis is Staphylococcal aureus. So, if there is nothing pointing towards another organism, you have to think of Staphylococcus aureus when you think of endocarditis. Okay, and it can cause some toxin-related infections. So, it can produce an exfoliative toxin A and B, which is causing our staphylococcal scalded skin syndrome, that is SSSS, staphylococcal scalded skin syndrome, by the exfoliative toxin A and B. It can cause toxic shock syndrome by the toxic shock syndrome toxin 1, TSST1. It can cause food poisoning by the enterotoxin, which is heat stable, and there is history of food intake, and within 24 hours the patient presents with severe vomiting. That is the staphylococcal enterotoxin food poisoning. Okay, coming to cons, which is Coagulase negative staphylococcus. They are mainly Staphylococcus epidermidis and Staphylococcus saprophyticus. And staphylococcal epidermidis can cause endocarditis in prosthetic wall. As I already mentioned, in a general case, the most common overall cause of endocarditis is Staphylococcus aureus, but in a prosthetic valve, think of Staphylococcus epidermidis. The treatment for both Staphylococcus and Streptococcus is mainly penicillin. For Staphylococcus, if it is sensitive, you have to use cloxacillin and go for penicillin. But if it is MRSA, methicillin resistant Staphylococcus aureus, you cannot give penicillin. They usually respond to vancomycin or linezolid, or you give teicoplanin. For acute rheumatic fever, you give penicillin with rifampicin. Okay. And again, for acute rheumatic fever, you give penicillin prophylaxis based on how much they need. Some people take it for 5 years, some for 10 years, and if there is proven cardiac failure, you give for lifelong. If there is carditis, you give for 10 years. Okay, that was gram-positive cocci. Now coming to gram-positive bacilli, which are rod-shaped gram-positive organism. So you can remember it like A, B, C, D, L. Okay, they are actinomyces, Bacillus anthracis, Clostridium species. You have diphtheria and listeria. Actinomyces, Bacillus anthracis, Clostridium, diphtheria, and listeria. Actinomyces can cause your actinomycosis. So actinomycetes is a broader class. It can include your actinomyces. It can include nocardia. So the class is called actinomycetes. So the major your manifestation and the one thing you have to remember is your actinomycosis. And usually in the question they give orofacial actinomycosis. There is some hint that is sulfur granules present. That is a hint for actinomycosis. You have your Bacillus anthracis, which is causing anthrax, which can be pulmonary anthrax or skin manifestation. Okay, cutaneous anthrax. Then you have a Clostridium, which is a broader class. It has Clostridium tetani, Clostridium difficile, things like that. We'll come to the details later. Then we have diphtheria and listeria. Listeria monocytogenes. Okay, it can cause meningitis. Coming to bacillus. Bacillus again have Bacillus anthracis and Bacillus cereus. And Bacillus anthracis can cause your cutaneous anthrax or pulmonary anthrax. Cutaneous anthrax mainly in the it's called Hyde-Potter's disease, and it is presented with a black eschar. Pulmonary anthrax, it's a Wool-Sorter's disease. It causes hemorrhagic pneumonia, and that is usually used as a bioterrorism, and it can also cause intestinal anthrax. Then Bacillus cereus, it is a causative agent of food poisoning. It is an emetic. It has emetic toxin and diarrheal toxin, usually associated with intake of fried rice. Okay, there is usually history of fried rice, and they present as a food infection. Think of Bacillus cereus. Okay, coming to Clostridium, we have four major species. Genus, that is Clostridium tetani, Clostridium botulinum, Clostridium difficile, and Clostridium perfringens. Clostridium tetani can cause tetanus by the production of tetanospasmin. That is the main toxin. It causes both tetanospasmin. It produces both tetanospasmin and retinolysin. Retinolysin causes hemolysis, but the major manifestation of tetanus is by the tetanospasmin, which is preventing the release of glycine and GABA from the Renshaw cell. So these are inhibitory neurotransmitters. So that is being prevented. So that causes spastic paralysis. So in tetanus we have spastic paralysis. In botulinum we have flaccid paralysis. Okay. So the clinical features are trismus, which is the difficulty in opening the jaw. Rhizus sardonicus. We have opisthotonus, that is a back arched posture. Dysphagia, and the treatment of choice is metronidazole. Okay, and the tetanospasmin, the tetanus-like picture can be seen in strychnine poisoning. Strychnine poisoning can mimic tetanus, but the difference is tetanospasmin act presynaptically, strychnine poisoning act postsynaptically. Okay, coming to Clostridium botulinum, It is usually spread through canned foods and honey. They prevent acetylcholine release. Acetylcholine is a stimulatory neurotransmitter. So that has been prevented, so it causes flaccid paralysis. Okay, and this Clostridium botulinum has a therapeutic role. It can be used in strabismus, blepharospasm, and myoclonus. Okay, we say there are 5 Ds in botulinum botulism. That is diplopia, dysphasia, dysarthria, dissenting paralysis, and decreased deep tendon reflexes. Diplopia, dysphasia, dysarthria, it is a dissenting paralysis. There are some conditions which is causing ascending paralysis like our GBS. Here there is dissenting paralysis and decreased deep tendon reflexes. Coming to Clostridium difficile. Clostridium difficile is famous for pseudomembranous colitis. In extreme condition, it can cause toxic megacoli. It is mainly due to antibiotic exposure or excess use of antibiotics, usually presented in hospitalized individuals who receive very much higher antibiotics. The major causative culprits are cephalosporins, clindamycin, ampicillin, and fluoroquinolones. Okay, cephalosporins, clindamycin, ampicillin, and fluoroquinolones. And we send Clostridium difficile toxin A and B and GDH for the stool will be sent for this screening. And the treatment of choice is oral vancomycin. Oral vancomycin is the treatment of choice for Clostridium difficile. It is postulated that vancomycin itself can cause, in excess can cause difficile pseudomembranous colitis, but it is the treatment of choice. The major culprits are clindamycin, cephalosporins, fluoroquinolones, and ampicillin. Coming to Clostridium perfringens, that is a causative agent of gas gangrene. It can cause myonecrosis, hemolysis, and hyperbaric oxygen is used as a treatment modality. Not the prime modality, but it has been used. The prime modality is surgical resection. Okay, that is Clostridium perfringens. That was the Clostridium species. Coming to diphtheria, which is another gram-positive bacilli. Diphtheria, it is Corynebacterium diphtheria. That is the full name of diphtheria. So diphtheria causes, the disease is also called diphtheria. And it causes pseudomembrane over the tonsil. So it is a causative agent of acute tonsillitis in children. So the treatment is ADS toxin, antidiphtherial serum toxin, and penicillin, and erythromycin is used for the carriers. Okay, it can cause pseudomembrane over the tonsil, and it causes a bull neck appearance. So it is a severe form of tonsillitis. Okay, coming to listeria. Listeria is a causative agent of, just like we told, it's a causative agent of meningitis, especially in the elderly, immunocompromised, and there is brainstem involvement. So if the question mentions something of meningitis with brainstem involvement and it's elderly individual or immunocompromised, think of listeria. They usually spread through unpasteurized dairy products, soft cheese, and there can be vertical transmission from mother to child, and that can cause neonatal meningitis. In the CSF picture, we see pleocytosis, and the organisms show a characteristic tumbling motility. The treatment of choice is amoxicillin or ampicillin, or we can get gentamicin. Okay, that was your gram-positive bacilli. To wrap up, we have also told their gram-positive bacilli consists of actinomycetes, and actinomyces is one of actinomycete species that cause actinomycosis, orofacial actinomycosis, and the characteristic feature is sulfur granules, which is the conglomeration of filamentous gram-positive bacilli. So they are filamentous, they act like fungus. So they were earlier thought as fungus, but now they are characterized as a bacteria, which is a gram-positive rod, and it causes sulfur granules with dense inflammatory cell infiltrates. They are usually termed as a sun ray appearance, with sulfur granules in the center and dense inflammatory cell infiltrates all around. That is actinomycosis. There is another gram-positive organism, which is of importance because there were some questions regarding this. That is Whipple disease caused by Trophirima whippleyi. Trophirima whippleyi, which is a bacilli, gram-positive bacilli. They occur within the macrophages, and they can be stained by the PAS stain. They can cause fever, abdominal pain, malabsorption, and diarrhea. There is migratory polyarthritis. There can be encephalopathy, lymphadenopathy. So this is a Whipple disease for you. It can also cause steatorrhea. Okay, it is caused by Trophirima whippleyi, mainly causing fever, abdominal pain, diarrhea with neurological manifestations and rheumatological manifestations like arthritis. It stains PAS stain positive. That was gram positive. Now coming to gram negative, which can again be classified to gram negative cocci and bacilli. Gram negative cocci is your Neisseria species, which is Neisseria meningitidis and Neisseria gonorrhea. Neisseria meningitidis is a diplococci. Neisseria gonorrhea is kidney shaped. Okay, Neisseria meningitidis can be lens or crescent shaped. It causes meningitis, and the usual picture is there is rash, there is septicemia, and there is meningitis. So rash with that is called meningococcal rash. Meningococcal rash with meningitis picture. Think of Neisseria meningitidis. It can cause Waterhouse-Friderichsen syndrome. Waterhouse-Friderichsen syndrome. And Neisseria gonorrhea is kidney shaped. It can cause urethritis, and in male it can cause Watercan perineum. In females it can cause cervicitis and vulvovaginitis. It can cause Fietz-Hugh-Curtis syndrome, that is perihepatitis associated with UTI in women. That is called Fietz-Hugh-Curtis syndrome. And it can cause in neonates when there is vertical transmission. It can cause ophthalmia neonatorum. Ophthalmia neonatorum due to vertical transmission from mother to child, usually during birth. Okay, and Waterhouse-Friderichsen syndrome, which can be a complication of meningitis, that is what does that mean? It is a group of symptoms caused when the adrenal glands fail to function normally. So it is affecting the adrenal glands. And the treatment of choice for ceftriaxone, treatment of choice for both meningitis and gonorrhea is ceftriaxone. And for gonorrheal infection, so gonorrhea causes gonococcal urethritis. And there is a major urethritis majorly classified into gonococcal and non-gonococcal urethritis. And we also give, along with for gonococcal infection also, we give doxy. We give doxy or azithromycin to cover chlamydia, because usually there is co-infection with chlamydia and chlamydia cannot be covered by ceftriaxone. So usually for urethritis we give ceftriaxone to cover gonorrhea and doxy to cover. Then we have another gram-negative cocci, which is Moraxella catarrhalis. Moraxella catarrhalis, it can cause otitis media. It can cause bronchitis, sinusitis, laryngitis, and usually in COPD patients, when there is some infection, think of Moraxella. Okay, so this is one of the commonest cause of infective exacerbation of COPD. Okay, that is Moraxella. Now, these are another way to look at gram-negative bacteria, because gram-negative bacteria is huge, you know. So just to remember, they are like gram-negative cocci, Neisseria meningitidis and Neisseria gonorrhea. Neisseria meningitidis is diplococci. Neisseria gonorrhea is kidney-shaped, and we have Vibrio cholerae, which are comma-shaped. These are the different shapes, okay? Treponema pallidum, which are spirochetes, and we have Escherichia coli or E. coli, which are gram-negative rod. We have Streptobacillus moniliformis, We have Helicobacter pylori. So this is yet another way to look at gram-negative bacteria. They can be classified as cocci, bacilli, and spirochetes. Now this is based on shape. Cocci can be Neisseria gonorrhea, Neisseria meningitidis, Moraxella catarrhalis, which we have seen already, and Bordetella pertussis, which is causing whooping cough, right? And we have pertussis vaccine also, which is given in combination with the as DPT vaccine or pentavalent vaccine, which is included in the immunization schedule. Okay, and then we have bacilli, which can be further classified into aerobic and anaerobic. Aerobic can be further classified as coliform and non-coliform, or lactose fermenters and non-lactose fermenters. Lactose fermenters are E. coli and Klebsiella. Non-lactose fermenters are H. influenza, Legionella, Salmonella, Shigella, and Campylobacter jejuni. Anaerobic can be Bacteroides and Fusobacterium. And spirochetes are Treponema pallidum, Leptospira, and Borrelia. We'll come to the details of each of this in a while. Okay, so this is a huge class of gram-negative bacilli. So you just need to remember the gram-positive cocci, gram-positive bacilli, that is ABCDL, actinomycetes, Bacillus anthracis, Clostridium, uh, and the diphtheria and listeria. You have to remember the gram-negative cocci, which are mainly Neisseria and Moraxella. Rest all are usually gram-negative bacilli. Just remember it like that, because gram-negative bacilli is a huge class. It includes E. coli, Klebsiella, Salmonella, Shigella, Legionella, H. pylori, Pseudomonas, Burkholderia, Acinetobacter, Campylobacter jejuni, and Brucella. E. coli is a usual causative organism for UTI. Klebsiella can cause hospital-acquired pneumonia and hospital-acquired infections. Salmonella can cause your typhoid fever. Shigella causes dysentery. Legionella is another cause of atypical pneumonia. H. pylori, which is causing duodenal and peptic ulcer. Pseudomonas, again, another cause for hospital-acquired infection. Burkholderia, which is also an acquired hospital-acquired infection. It can be Burkholderia serpitia and Burkholderia pseudomoli. We'll come to that later. We have Acinetobacter, again a hospital-acquired infection. Campylobacter jejuni and Brucella. So E. coli, it is a usual causative organism of UTI. It can cause also diarrhea and neonatal meningitis. And there is a class called ESBL E. coli. ESBL means extended spectrum beta lactamase producing E. coli. So they will be resistant to the penicillin, cephalosporins. So the drug of choice for ESBL E. coli is carbapenem. There has been questions regarding this. So remember, for ESBL E. coli, you give carbapenem because they are resistant to both penicillin and cephalosporins. And there is another strain of E. coli which is called E. coli O157H7, which is because E. coli has three strains like O, K, H, and they are classified further based on the this O, H, and K. So one of the strain is O157H7, which is important because it is associated with HUS, hemolytic uremic syndrome. Usually following diarrhea, the patient was sent with hematuria, a picture of hemolysis, and there is hematuria. And that is called hemolytic uremic syndrome. Their renal manifestation is more. It's a kind of microangiopathic hemolytic anemia, MAHA. And in TTP, we also know that MAHA, one type of MAHA is TTP. TTP, where we have less of renal manifestation. In HUS, we have more renal manifestations. So that is E. coli 157H7. Coming to Salmonella. Salmonella is a causative organism of enteric fever, typhoid fever. And there is relative bradycardia. Salmonella typhoid, one of the classic picture is relative bradycardia. So there is high fever. With increase in temperature, we usually have tachycardia. But in this case, even with high fever, we are having a relative bradycardia, which means that heart rate will be around 80, 90 maybe, but it is not as in par with the increase in temperature. Then we have rose spots, which are the rash found in typhoid fever. And stool culture is usually positive in the first week. Vidal test is also not now widely used. Now the diagnosis of choice is blood culture. Okay, and gallbladder can act as reservoir. In such patients, they may need cholecystectomy. And you may have heard of typhoid Mary. She was a chronic carrier. She has been a cook, and she has contracted the disease to so many people because she has been a silent carrier. So there is a situation where typhoid can be chronically carried. Especially gallbladder acts as reservoir, and reinfection also can happen. In that case, you need to go for a cholecystectomy. Okay. In Salmonella, we have O and H antigen, and in Vidal test also we are making the use of this O and H antigen. This O antigen and the antibody against this O antigen will appear early, disappear early. So that if antibody against O antigen is positive, it indicates a recent infection. However, H antigen, the antibody against H antigen, the antibody appears late and disappears late. So that may indicate a convalescent stage. So if both O and H are positive, that means an active infection. If only H is positive, that means a convalescent stage. Okay. Coming to Campylobacter jejuni, it can cause bloody diarrhea. Okay, like our Shigella, it can cause bloody diarrhea. And this is one of the commonest infection which is associated with GBS. Okay, GBS is post-infectious, demyelinating, acute demyelinating polyneuropathy. So that this infection, Campylobacter jejuni, is the commonest infection associated with GBS. It can also cause reactive arthritis, that is post-infectious. There can be arthritis and arthralgia, and it is associated with HLA-B27. HLA-B27. There has been a question which asked which HLA is associated with reactive arthritis. That is HLA-B27. Again, seronegative spondyloarthritis, they are all associated with HLA-B27. And drug of choice for Campylobacter jejuni is clarithromycin. Coming to brucella. Brucella causes brucellosis. It's a zoonotic disease and contracted from sheep, goat, or cattle. Again, it's a typhoid-like illness, and the treatment of choice is streptomycin with doxycycline. Brucella is usually characterized with a triad of fever with night sweats, arthralgia, and hepatosplenomegaly. So there is fever with night sweats, arthralgia, and hepatosplenomegaly. So zoonotic infection, drug of choice is streptomycin and doxycycline. Coming to Burkholderia, as I told, Burkholderia has two genus, Burkholderia pseudomallei and Burkholderia cepacia. Burkholderia pseudomallei is a causative organism for melioidosis. It can cause pulmonary manifestations, it can cause skin ulcers, it can cause lymph node enlargement. Okay, lymphadenopathy. So there are skin ulcers, pulmonary manifestations, and lymphadenopathy. And the drug of choice, it requires a little bit prolonged treatment. Ceftazidime is given for the initial 2 weeks, then changed to oral cotrimoxazole for the 12 weeks. So total you need 14 weeks treatment. So it's a prolonged treatment for Burkholderia pseudomallei. Okay, so that is melioidosis. Burkholderia cepacia can cause cepacia syndrome, especially in cystic fibrosis patients. Okay, cepacia. Okay, coming to H. pylori, Helicobacter pylori. It can cause peptic ulcer. It is associated with gastric carcinoma and gastritis. Okay, pan-gastritis. It can cause gastritis, and the diagnosis is by urea breath test. Okay, it is H. pylori, and if H. pylori is found positive, we may not start treatment then and there. If they are asymptomatic, you might not start the treatment. But if they are symptomatic, they have maybe peptic ulcer, they have a typical cells in the gastric, morphology. That means maybe they are indicated for treatment. And the treatment regimen are two kinds of treatment regimen. One is the triple drug therapy with the OCA or OCM regimen. That is omeprazole, clarithromycin, and amoxicillin, or omeprazole, clarithromycin, and metronidazole. Okay, we are using omeprazole, which is a PPI. We are using clarithromycin, macrolide, antibiotic, and amoxicillin. Instead of amoxicillin, we can also use metronidazole. Once this regimen is given for 14 days, we then do a urea breath test. If urea breath test becomes positive, that means it was resistant to the first regime. Then we go for urea breath test is repeated after 1 month, and if again that is positive, means they have not responded to the regimen. So we go for the second line quadruple drug therapy with OBMT regimen. Again, omeprazole, uh, bismuth subsalicylate, metronidazole, and tetracycline. So that is the OBMT regimen, quadruple therapy, which is second line, given for again 14 days. So that is H. pylori. Okay, so those were some of the gram-negative bacilli. Coming to spirochete, they are Treponema, Leptospira, and Borrelia. Your Treponema again has two genus, Treponema pallidum, which causes syphilis, and Treponema pertinue, which causes yos. Syphilis, you have primary, secondary, latent, and late or tertiary syphilis. So primary syphilis is characterized by chancre, which are painless genital ulcers with painless lymphadenopathy. So primary syphilis, we have painless ulcers with painless lymphadenopathy, and they're usually single. Secondary syphilis, which happens a little bit late, months later, uh, that is characterized by rash in the palms and soles, and we have also condylomata lata. Condylomata lata. Now there is a latent syphilis where the patient is uh, asymptomatic, but they continue to continue to be infective. Okay. And condylomata lata is a benign and painless cutaneous manifestation of secondary syphilis. They are hyperpigmented growths, typically located in the genital area. Okay, so that is condylomata lata, and latent syphilis can progress to either late syphilis. They may spontaneously resolve. Spontaneously resolve means after many months and years, it may resolve, or it may progress to late syphilis. Later tertiary syphilis have three kinds of manifestations. One are gammas. We can have cardiovascular manifestations and neurological manifestations. Okay, and gammas are they are deep subcutaneous nodule that grows very gradually and adheres to the skin. Okay, so that is gammas. Uh, So the primary syphilis we have chancre, which is painless genital ulcer. Secondary syphilis we have condylomata lata, which is uh, skin colored or hyperpigmented growth in the genital region. Late syphilis we have gamma, subcutaneous nodules. We can have cardiovascular manifestations and neurological manifestations. Neurological manifestations can be uh, different variants of maybe genital paresis of insane. It may be Tabes dorsalis. It can be meningitis or meningovascular manifestations. So that was syphilis. Now we have congenital syphilis, which is with the vertical transmission from mother to child. They can be characterized by frontal bossing, saddle nose deformity. The child can have learning disabilities and paroxysmal globinuria, or others like rashes. They can have anemia and thrombocytopenia, long-bone abnormalities, hepatic splenomegaly. They can have sensory neural hearing loss, interstitial keratitis, secondary glaucoma, corneal scarring and optic atrophy. They have Clarton's joints, that is joint deformity, and eversion. So remember some terminology: frontal bossing, saddle nose deformity, sensory neural hearing loss, interstitial keratitis. So they have ocular manifestations like interstitial keratitis, secondary glaucoma. They have saddle nose and hearing loss, and Clarton's joints and eversion, and hematological manifestation like anemia, thrombocytopenia. And the serological test for syphilis are specific tests and non-specific tests. Non-specific tests are non-treponemal tests like VDR and RPR, and specific tests are treponemal test. Treponema uh, pallidum particle agglutination test (TPPA), Treponema pallidum immobilization test, that is TPI, and TPA. Okay, TPA is treponemal antibody test. Okay, Treponema pallidum antibody test, Treponema pallidum particle agglutination test, and Treponema pallidum immobilization test. Okay, and the treatment of choice for syphilis is penicillin. Penicillin. Okay. Coming to Borrelia, Borrelia uh, has two genus: Borrelia recurrentis and Borrelia burgdorferi. Borrelia recurrentis cause relapsing fever, and Borrelia burgdorferi cause Lyme disease. This relapsing fever has antigenic variation, and the vector for the disease is louse, and the treatment of choice is doxycycline. So that is relapsing fever, Borrelia recurrentis. Borrelia burgdorferi cause Lyme disease, which is tick-borne. The vector is tick, and it can cause various clinical manifestations like erythema migrans, arthritis, encephalopathy, acrodermatitis. Erythema migrans, arthritis, encephalopathy, and acrodermatitis. The causative organism is Borrelia burgdorferi. There has been questions on that. Coming to Leptospira, the genus is Leptospira interrogans, and it causes leptospirosis. And the epidemiological triad of leptospira is rainfall, rice field, and rodents. So if there is history suggesting of the patient has been working in a rice field, or the patient has walked, in a dirty water in the rainy season, or there has been not direct exposure to rodents. Rodents urine may be spread in the rice field and dirty water. That is how it gets spread. In the serious condition, it causes Fields disease, which is characterized by hepatorenal. It's called hepatorenal hemorrhagic syndrome. So it can cause hepatitis. It can cause renal manifestation, renal shutdown, and pulmonary hemorrhage. Okay, so that was leptospirosis. We'll come to another class, which is rickettsia. So rickettsia can be classified into three groups: typhus group, spotted fever group, and a scrub typhus. Again, typhus group can be causing epidemic typhus and the one causing endemic typhus. Epidemic typhus is by Rickettsia prowazekii. Okay, epidemic prowazekii. And the vector for that is louse. Okay, so louse, epidemic typhus, and Rickettsia prowazekii. And in that, 80% presents with rash, and the rash can be seen all over except palm and sole. And the endemic typhus is by Rickettsia typhi, and the vector for that is flea. Okay. Spotted fever group is Rickettsia rickettsii, Rickettsia conori, Rickettsia africae, and Rickettsia acari. Rickettsia rickettsii is the most important one, that is the Rocky Mountain spotted fever, RMS, Rocky Mountain spotted fever, and the vector for that is tick-borne. So Rickettsia prowazekii epidemic typhus is louse-borne, Rickettsia rickettsii, Rocky Mountain spotted fever is tick-borne. And usually the rash is 90% in patients present with a rash, which are usually present in the extremities. The Rickettsia gonorrhoeae Indian tick typhus, again it is tick-borne. Africae African tick bite fever, which is again tick-borne. And Rickettsia acaricus rickettsial pox, which is mite-borne. For scrub typhus, the species is Orangia Sudzuka mushi, and the disease is scrub typhus. And the vector for that is a mite, a trombiculate mite. So we say there is an epidemiological tetrad for the scrub typhus. So there is the trombiculate mite. There should be pet season, and okay. So we'll come to that later. That is called it epidemiological tetrad. And this is one of mite. So, epidemic typhus, Rickettsia prowazekii, louse-borne, Rocky Mountain spotted fever, Rickettsia rickettsii, tick-borne, Orange Suzugamushi, scrub typhus, mite-borne. Okay, and that is characterized by our eschar. Eschar. Okay, the scrub typhus, it's also called the chicarosis because the larval stage of that mite, trombiculate mite, is called chickers. That is why it is called chicarosis. And it has a characteristic eschar which is black in color. The triad of scrub typhus is an eschar, renal lymph node enlargement, and so there is eschar, regional lymph node rash. And the zoonotic tetrad is called the that are essential for the scrub typhus to spread. There is initially we need the trombiculate mite, small mammals like rats, scrub vegetation is important, that's why it's called scrub typhus, and wet season. This is the zoonotic tetrad for scrub typhus. Okay, the treatment of choice is doxycycline. Then another group of organism called Bartonella, the Bartonella species. There are two genus, three genus, Bacilliformis. Bartonella henselae is important because it causes cat scratch disease. In the reservoir are cats and other felines, and it is usually spread by exposure to cat by scratch or bite. And the cat fleas are associated with cat to cat transmission, but not cat to human transmission. So mainly by scratch or bite. Cat scratch disease. The typical form is presenting with lymph node enlargement. Most common site is axillary and epitrochlear, and there are painless pustules. And a typical form of cat scratch disease can involve other organs as well. And the staining we use for that is Warthin starry silver nitrate staining. Warthin starry silver nitrate staining for Bartonella henselae. Then a bacillary angiomatosis, another disease caused by that. Vascular lesions in skin and other seen in HIV infected people. Okay, can cause bacteremia and okay, and now La Quintana causes trench fever, and the reservoir are humans and transmitted by louse. So this is another louse-borne disease. One was an epidemic typhus. Now we have Bartonella quintana, which causes trench fever, again louse-borne. Bartonella bacilliformis causes Oroya fever, and the transmission is by sandfly. Okay, remember cat scratch disease, characterized by lymph node enlargement, most commonly axillary and epitrochlear, and veinless pustules, and it is spread by exposure to cat. Bartonella henselae is the organism. Now we have chlamydia. We have Chlamydia trachomatis, which is one of the important genus of chlamydia. Chlamydia produce inclusion bodies, just like our viruses. They produce inclusion bodies. They're called energy parasite because they cannot produce their own ATP. They use the machinery of the host to produce their ATP. That's why it is called energy parasite. And the life cycle of chlamydia consists of two forms, elementary body and reticulate body. Elementary body is the infective form, reticulate body is the replicating form. So elementary body is the infector form, reticulate body is the replicating form. So elementary body is extracellular, reticulate body is inside the host cell, and elementary body has a rigid cell wall while reticulate body has a fragile cell wall. Okay, so elementary body enters the cell because that is infective form. It then converts to the reticulate body. Reticulate body starts replicating and forms newer uh, uh, but again to elementary body, come out of the cell, reinfect. This is the life cycle of chlamydia. There's two forms, elementary body and reticulate body. The important species are genuses are Chlamydia trachomatis, Chlamydophila psittaci, and Chlamydophila pneumonia. Chlamydia trachomatis, again there are different serovas, that is A, B, BA, and C. That is the causative for trachoma, which is characterized by follicular hypertrophy, papillary hyperplasia, there is pannus and cystitization. These are the ocular manifestation. And D to K serovas cause inclusion conjunctivitis, again ocular manifestation. But L1, L2, L3 causes LGV, which is lymphogranuloma venereum, which is a kind of STD, sexually transmitted infection. It causes painless ulcer with painful lymph node enlargement. Painless ulcer with painful lymph node enlargement. In syphilis, we have painless ulcer with painless lymph node enlargement. Here we have painless ulcer with painful regional lymph nodes, and the lymph nodes are called buboes. Okay, the trachomatis can complicate to form Ritter syndrome, again associated with HLA-B27, like our arthritis, reactive arthritis. Then Fitzhugh-Curtis syndrome, which is perihepatitis. The treatment of choice is azithromycin. So chlamydia trachomatis can cause trachoma. It can cause inclusion conjunctivitis. L1, L2, L3 serovas can cause lymphogranuloma venereum. So in order to cover chlamydial infection, it can cause genital ulcers, just like we told, lymphogranuloma venereum. In order to cover that, it can cause urethritis, non-gonococcal urethritis. Along with gonococcal infection, if we identify a gonococcal infection, along with giving ceftriaxone for gonococcal, we usually give doxycycline or azithromycin to cover chlamydia because they are usually co-infected, because both can be spread, transmitted sexually. So it is covered. Then we have Chlamydophila psittaci, which is a causative organism for psittacosis, and it is manifesting as a atypical pneumonia, spread by pet birds like parrot. The treatment of choice is tetracycline. Again, Chlamydophila pneumonia can cause community-acquired pneumonia. The treatment of choice is again tetracycline. So that was chlamydia. Coming to mycoplasma, it is the smallest free-living organism. It is also called Eaton's agent. It lacks cell wall, okay, and it is one of the causative organisms for atypical pneumonia. So it can cause erythema multiforme, it can cause rash, and one of the key feature given in the question will be cold agglutination test is positive. So it causes hemolysis, intravascular hemolysis, because they are called agglutination test positive. There are antibodies, autoantibodies produced, so there causes intravascular hemolysis. So cold agglutination test will be positive. So that is the key in the question to identify that it's mycoplasma. Or there may be history of presentation of rash with features of pneumonia. And the treatment of choice is azithromycin. So that's all. That was the bacteriology in the simplest and a little bit detailed. Keep following for more updates on MRCP. Thank you so much.